Thanks for inviting me to give this presentation today. So I'm going to talk about cerebral autoregulation. I don't have any disclosures. I'll begin by talking about the current state, the fact that when we're talking about cerebral autoregulation, there's a reliance of information on cerebral blood flow velocities or cerebral blood flow, right? And then talk about healthy autoregulation and then some case uses focusing on traumatic brain injury, which is, I would say, the condition that has a very large body of literature, and then touching on diabetic ketoacidosis and critical illness, and then conclude by talking about research, education, and clinical gaps. So, the rationale for studying and thinking and practicing, uh, you know, considering cerebral autoregulation status is that critical illness is a big problem. Multi-organ effects impact cerebral perfusion. Cerebral hypoperfusion or hyperperfusion can result in ischemia or hemorrhage. Cerebral perfusion pressure states change, if not continuously, definitively by the day. Systemic hemodynamics affect cerebral perfusion. The regulation of cerebral perfusion is important, and hemodynamic instability is common and unwanted. So let's talk about reliance on cerebral blood flow velocity in this case, because we're talking about transcranial Dopplers and how that informs our understanding of cerebral autoregulation. So first, um, there's been a lot of discussion this morning about the lack of normative data. Very important, because in order to understand how cerebral autoregulation is affected in disease states, we have to understand how cerebral autoregulation functions in healthy states across the age group and by sex. And in order to understand that, we rely on our knowledge of what happens to cerebral blood flow velocity by age group and by sex in pediatric medicine. So I'll begin by talking about the fact that cerebral blood flow velocity does change with age. There are studies that we and others have done to show those changes over time. So this is one study showing that if you look at this is an older study, that there is an increase between birth and 6 months of age. And then this study only went to 30 months of age. But if you can look at the early period, there's a significant increase in cerebral blood flow during the early period. So again, showing that we're not to use static values of, let's say, 50 mils per 100 grams per minute, which is the adult values, that we have to consider age. And so, again, just keeping in mind that cerebral blood flow volume and cerebral blood flow itself are lower for younger kids and increase with age across the infancy and moving on. And this is because cerebral vascular resistance decreases over as kids grow. And you can see that there are some naters that we naturally observe. And this loss of cerebral vascular resistance that normally happens is associated with gray matter increases and then subsequent decreases as children approach adolescence. So you're talking about peak CBFV somewhere around 6 to 9 years of age, and this corresponds to peak synaptic density around that same period of time, after which pruning happens. So this is a period of rapid development, rapid adjustments, and then we are supposed to think about these things and these values and these physiological changes as we interpret our data using TCD and other measures. This is a study that we did in 2005 where we prospectively enrolled healthy children and performed TCDs to look at and develop normative values across the age groups. And so what you see in the left panel here is, again, this increase in CBFV overall for boys and girls. Those are in the green bars. And then if you break out the data by boys and girls, you see the sex effects. You'll see that girls have higher VMCAs than boys. And this is also true for the posterior circulation. for when we examined VBAS, so basilar artery flow velocities. And so now I'm introducing the idea that it's not just about age, it's about age and sex. And so when we consider normative data for TCDs, we should be really using these normative data to understand what may represent ischemic or hyperemic states. So these are the summative tabular values for VBAS and VMCA for girls and for boys. As expected, VMCA is higher than VBAS for both groups, but then you can see that within the anterior and posterior circulations, and this is true for prepubertal and pubertal children equally, that VMCA is higher for girls than boys, and similar but less of a difference for VBAS. So, with that in mind, let's talk about cerebral autoregulation. And so cerebral autoregulation is the ability of the brain to regulate blood flow across a range of blood pressures through constriction and dilation of the Peel vessels. And because TCD does not measure CBF directly, we're thinking about VMCA and VBAS and other measures, other locations of the circle of Willis as surrogates for CBF, assuming certain static conditions such as CO2 reactivity, for example. So when disease states impact children, this process of cerebral autoregulation becomes impaired and the brain becomes pressure passive. In other words, perfusion to the brain is directly dependent on the blood pressure that is provided, that patients have. And this line, although I've drawn it sort of to represent a steep curve, there are a number of articles in the adult and pediatric literature to show that this line can actually have less of a slope, can have more of a slope, and that slope changes over time during the first week or 2 weeks after the initial injury or illness begins. And the other issue is that when we're considering cerebral autoregulation, we need to think about it in terms of what is our reference point. Are we using mean arterial pressures or cerebral perfusion pressures? Because not all disease states have ICP monitoring. Hepatic encephalopathy, lots of studies done there, sepsis, diabetic ketoacidosis, while we are aware of cerebral edema occurring as a unifying complication of a number of metabolic conditions. ICP monitoring is in pediatric critical care most commonly done when it's done in traumatic brain injury. So standardizing whether we're using MAP or some estimate of CPP becomes important, but this is understudied and not uniform. So what are the functions and how do we test cerebral autoregulation? Well, the function is that it modulates the effect under normal conditions of MAP CPP changes on blood flow in the healthy state. It's actually a cerebral protective mechanism to prevent ischemia and hyperemia and breakthrough perfusion. And then this protection of cerebral function actually does not work, goes awry in disease states. So cerebral autoregulation testing to understand this process using TCD can be achieved using static testing, dynamic testing, or tilt testing. And these are protocols that we clinically have used at Harborview Medical Center for over 20 years. And we've developed some of these protocols for children specifically. So the classic method for cerebral autoregulation testing involves xenon to evaluate cerebral blood flow, but this is not available, not done commonly. When using TCD methodology, static testing involves slowly increasing blood pressure to evaluate the change in VMCA and then calculating the autoregulatory index. Dynamic testing frequently will involve the use of a thigh cuff to increase blood pressure and then deflating the cuff to look at the drop and then the rate of return of VMC back to normal. There's the transient hyperemic response ratio, which involves carotid compression, and then evaluating decrease and then increase in CBFV. And then there are non-invasive, non-invasive methods that have been described where TCD data are correlated with other data over time. But I would argue that that's not really testing autoregulation, which is my biggest challenge with some of the data where map and flow velocity data are correlated over time in the ICU setting. And then tilt testing is adapted from cardiology. I like it because it actually provides a stimulus to evaluate the change, and you're actually testing the process that you're supposed to test. Now, keeping in mind that testing autoregulation has to be done under certain other static conditions, such as maintenance of normocapnia, because CO2 is a very powerful driver and regulator of cerebral blood flow. And so, even 1 to 3 millimeters of change in CO2, you're going to get, 3% or so increase in cerebral blood flow. At least that's what's true from the adult data. Pediatric data are yet to be established in the healthy and diseased states, but nonetheless, I think what's most important is that when we're doing cerebral autoregulation testing formally, and also by extension, when we're evaluating TCD-based flow velocity data in conditions that CO2 really needs to be sitting somewhere between 35 and 40 millimeters of mercury. And a lot of the studies that are published don't include the CO2 conditions at the time of VMCA acquisition or cerebral autoregulation testing, which is a methodological flaw in that work. So let's talk about the healthy state, right? So what happens, what can neonates and babies autoregulate cerebral blood flow? This is a study that was published in 2018 of 44 full-term neonates, 16 without congenital heart disease. And what these investigators reported was that neonates with congenital heart disease had lower RSO2, and they used cerebral oximetry and tilt testing to evaluate cerebral autoregulation. And this is a question that came up in the chat, which is oximetry better or TCD? And I think Brian responded to that by talking about sort of cerebral oximetry is even a more distal I wouldn't even say measure, but you're sort of making certain assumptions about blood flow that leads to cerebral oxygenation. So this study is important in the sense that it's talking about cerebral oxygenation being, you know, better in healthy term neonates without congenital heart disease. But I would argue that they're really not testing the process of autoregulation because they're not looking at flow or a surrogate, a more proximate measure of flow. We conducted a study recently published to examine cerebral autoregulation in healthy newborns that we recruited in the labor and delivery suite and performed autoregulation testing within 48 hours of birth. And this is a small series of 10 healthy newborns, 5 boys and 5 girls who were term greater than 37 weeks with no confounding conditions such as ABO incompatibility and history of healthy pregnancies. And what we have shown here for the first time is that actually provided the values, the reference values for autoregulatory indices for healthy newborns, and that is about 0.83 with a standard deviation of zero point 0.3. So this shows, at least in these 10 healthy newborns, that autoregulation, that process is intact. Now, the other point I want to make here is that if you're looking at resting mean arterial pressure, it's about 56 millimeters of mercury, and the flow velocities of these newborn babies is about 26. And this was important for us to show because it replicates and reproduces prior work from the study that I first shared with you when we began talking about this, where CBF is lower in neonates and then increases over time. And these values using TCD are very similar to the data produced when they were acquired from more direct CBF measures. So this again sort of suggests that there may be a value for using TCD to study newborns. We also established Lindegard indices for children, for healthy children 10 to 16 years of age. And this has been a void in the literature for decades. These are healthy children recruited, where we looked at the ratio of the external carotid to the internal carotid artery and compared the ratio to looking at VMCA. And so now these data inform um, our care of children with vasospasm, whether it be traumatic or aneurysmal. So we've talked a little bit about newborns, and then if you extend that across the age continuum, this study shows that the autoregulatory index is actually pretty preserved across the ages in pediatrics, and is quite comparable to 18 to 41-year-old adults. So the ability, the inherent ability of the autoregulatory process is actually pretty established at birth, and continues throughout adulthood. So I think these data provide the evidence for our assumptions that autoregulation is intact. Now, there are sex differences in the ability to autoregulate blood flow, just as we've shown that there are sex differences in VMCA. And this is where it becomes a little bit tricky in the sense that this is a small study, so it needs to be replicated. But these data suggest that the autoregulation ability of healthy 4 to 16-year-old girls is actually higher in the basilar artery than boys. And then when you're looking at VMCA, that the ARIs are higher for healthy boys than there are for girls. So again, suggesting that there are some sex differences that need to be studied from a mechanistic standpoint, and we don't have enough data, but these small studies suggest that there are sex effects that need to be considered in our interpretation of ARI data as well as VMCA data that we just talked about. Now, a very important question in pediatrics, whether it's pediatric emergency medicine, critical care, pediatric anesthesiology, I'm an anesthesiologist, is to really think about what is the lower limit of cerebral autoregulation. And for I would say many of us, if we were to take a poll and ask that question, many of us might instinctively say the lower limit of autoregulation is lower in younger children because their resting mean arterial pressures are lower, and we tolerate deliberate hypotension more commonly under a variety of clinical scenarios in pediatrics for younger children compared to older children. So we tested this where we enrolled 53 children and decreased their blood pressure to a mean of 40, and then using vasoactive agents increased their blood pressure, and simultaneously using transcranial Doppler ultrasonography developed these types of curves by age group. So this is VMCA on the y-axis, MAP on the x-axis, and these are healthy children. And we had, I would say, 13 children in each group. The study was powered appropriately. And what we demonstrated is that the lower limit of autoregulation is actually the same as it is in older kids. This then led to the idea of lower limit reserve, which means what is the difference between the MAP and the lower limit of autoregulation. And if you can see here, the lower limit reserve actually increases with age. In other words, younger children may be more at risk for cerebral ischemia than older children. In fact, this is our clinical experience in the field of traumatic brain injury, which is a lot of the work that I've done over the past 2 decades. And then if you look at autoregulatory reserve as a calculated measure, you'll see that that difference also increases over the age groups. So in fact, our tolerance of deliberate hypotension, I would argue, is probably not warranted because children have a lot less reserve between the resting MAPs and their lower limit of autoregulation. As an anesthesiologist, this is important. Many injured children and children with critical illness come to the operating room for procedures. They come during the acute period, they come during the convalescent period, they come after they're well. And so we tested the autoregulation during sevoflurane anesthesia in children of different age groups. And you can see here that autoregulation under certain medication conditions, low dose sevoflurane anesthesia, is actually preserved, which suggests that it's a good agent to use from that perspective. And this preservation is true across the age groups. We didn't have enough sample size to really talk about boys and girls. So if we synthesize this, what does the healthy autoregulation landscape look like? Well, so we remember the small picture here is just reminding us of the differences in VMCA for VMCA and VBAS across the age groups. There's this, it starts out low, it peaks during early childhood, decreases, and then approaches steady state or adult levels by adolescence. So if you look here at the data for that by MAP, right? Those are the red dots. Mean arterial pressure increases with age. The Harriet Lane Handbook has been very consistent over time in providing reference values for that, and that is true, and we use that in clinical practice. If the lower limit of autoregulation um, is actually stable over time, that is, and the blue dots represent what we have provided evidence for, then really the delta, which is the lower limit reserve, you can see these green dots, actually increases over time. Again, suggesting that our tolerance of hypotension in the intensive care units, in the operating rooms, in the emergency departments are probably not great, at least from a theoretical physiological standpoint. So let's look at use case number one, and this is where the majority of data comes from, which is traumatic brain injury, which is a leading global public health problem, particularly in low middle income countries. So this is static autoregulation testing, where we increased mean arterial pressure and examined left and right VMCAs, looking at the anterior circulation. This is a screenshot of the TCD monitor. To the right of that is the screenshot of what intact autoregulation looks like in real time, where you increase MAP and VMCA on the left and right remains relatively constant. Now the scale is a little different on the panel to the right, but nonetheless, you can see here that the red line shows as MAP is decreased, VMCA decreases proportionately. As MAP is increased, VMCA increases. And this is reflective of impaired or absent autoregulation. So there are we typically use intravenous infusions of phenylephrine to increase blood pressure, record the data and the delta for VMCA changes, and then also MAP changes and calculate an autoregulatory index, and use a binary threshold of ARI greater than or equal to 0.4 to reflect intact cerebral autoregulation, recognizing that this is really a continuum between 0 and 1, where 1 is perfect and 0 is absent autoregulation. So when we examine flow velocities in acute TBI versus healthy controls, hyperemia is actually rare, and this is consistent with the work that Peter Skippen has done out of Canada, initially landmark work showing that ischemia is the predominant pathophysiology. However, there is variation in that between subjects and over days, and this is a band of girls and boys. Now we're trying to split out our data by sex. This is the band of VMCA by CPP, and you can see here that there's a lot of variation in middle cerebral artery flow velocity, regardless of what the CPP is, and there's also variation in ICP. And the more frequent data in the boy category reflects the fact that TBI is more common in boys than in girls, but nonetheless showing that it's very easy to say, this is what happens in aggregate, but in fact, there's so much heterogeneity in what happens by day, by age, and by sex that we really need to be thinking about TCD, as was previously discussed, at bedside, personalized, and point of care. In addition, TCD data needs to be thought of with regard to the CT lesion in the hemispheres. For example, if you have left-sided lesions, do you have autoregulation that's impaired across both hemispheres? Is it global? Is it focal? And how much of that matters? And it's really a little bit unclear because there are no large-scale studies testing this. But what we do know is that autoregulation is worse in the hemisphere with the documented TBI lesion, but impairment also occurs in the hemisphere with negative head CT findings. Now, this may be related to midline shift, compression that is not evident on CT, or evolving TBI that will only become apparent as we progress from day 1 to day 2. Now, understanding whether autoregulation and autoregulatory changes are a phenomenology or actually whether they matter to outcomes is an important question. And we tried to answer this a few years ago, where we enrolled 37 children with traumatic brain injury. What we found was that children younger than age 4 had a higher incidence of impaired autoregulation and worse 12-month GOS scores. These are children we followed for about a year. And what we were able to show was that age less than 4 years and low GCS were independently associated with impaired cerebral autoregulation, suggesting that in addition to the traditionally examined epidemiological risk factors that patients bring to the hospital, such as age, we also are worried now about this physiological process that is in front of us that we don't yet have a treatment for. So if you take impaired autoregulation and put it into statistical models along with hypotension, which is a known independent risk factor for poor outcome, you can see that it is independently associated with poor outcome in addition to hypotension. Well, there is also this idea or this confusion or concern or lack of information, all of those, about whether children with inflicted traumatic brain injury are somehow different in terms of their physiological processes than children who have traumatic brain injury from, um, non-inflicted causes. So it's very difficult to do research in children with inflicted TBI for a number of reasons. But we actually studied autoregulation in a small series of children who had inflicted a TBI. And what we were able to show here is that all children with inflicted TBI had poor outcome in these series, and none had intact cerebral autoregulation in both hemispheres. And so this suggests that there may be some differences, not only by age, but also by mechanism of injury with regards to cerebral autoregulation status in our intensive care units. In recent years, we have been admitting more children to the ICU who have complex, moderate TBI, who are at concern, who are at risk for deterioration. And some of these patients have had TBI from sports-related injuries. So we enrolled 31 children who underwent 56 autoregulation tests, and these children all had complex, mild traumatic brain injury. And these children, we might have guessed would not have impaired autoregulation, but in fact, 68% and 32% of tests demonstrated unilateral and bilateral impairment, respectively, most commonly during the first 5 days after injury. And these children tended to have subdural hematoma, epidural hematoma, subarachnoid hemorrhage. And so this raises awareness that the idea that autoregulation is impaired is not really just for the most severely injured children, but also is related to complex mild and moderate TBI. As an anesthesiologist, we take care of children who are who are undergoing procedures. These children often have traumatic brain injury. Studied children under anesthesia for during surgery, and showed here that even children who have severe, moderate, or mild TBI who come down acutely after their TBI actually have impairment of autoregulation. The frequency is related to the TBI severity, but nonetheless, kids who are having anesthetic care, sometimes for 2, 4, 6 hours, as the surgeons are working, if autoregulation is impaired and patients are hypotensive, that's an at-risk period. Now, this is just, I'll just show you, this is a study in diabetic ketoacidosis. We've done some of this work because there was a controversy there has been around whether the genesis of cerebral edema is due to cerebral ischemia or hyperemia. In DKA, my sense that it's really hyperemic, a hyperemic problem due to the inflammation in DKA. And so we studied autoregulation in these children in the ICU. And what you'll see here in the graph to the left, the blue bars are impaired autoregulation, the green are intact, and this is time one, time two, and then these are our healthy controls that we enrolled concurrently from the endocrinology clinic who had patients who had type 1 diabetes but no DKA. And what you can see here is, of course, the children who have type 1 diabetes but no DKA have intact autoregulation. Those who have type 1 diabetes and DKA, when they acutely come in within 24 hours to the ICU, they are impaired. They get better over time. And those children who have cerebral edema actually have more impairment than children who do not have cerebral edema with DKA. So again, suggesting that there's a utility for TCD in critical illness in studying children who are admitted with DKA at risk for cerebral edema. So the research gaps in the field of cerebral autoregulation, I think, are large. We don't know a lot about mechanisms. We don't know a lot about autonomic function and healthy state and critical illness in children in general. We don't really have a solution for fixing dysautoregulation. We don't really understand blood pressure control and how to streamline that when autoregulation is impaired. We need more data on normative and disease states, and particularly sex effects. We need to understand what is the value of TCD to study non-invasive ICP, the role of studying CO2 reactivity and CPP effects, medication and condition effects, and the relative value of TCD with other neuromonitoring, such as PbO2, which provides useful information for oxygenation. I would say specific to cerebral autoregulation, really the education gaps are also large. The major resources are the published literature. We rely on TCD courses, our experiences. There's limitations in what postgraduate education offers, has been previously discussed, and really TCD certification is not required. There are no real credentialing requirements at our center. We have a lot of experience with TCD. Renee Aslett developed TCD at our facility, and so since the 1980s, we've been a pioneer in adult and pediatric TCD use and research. And so a lot of us have sort of learned on the job how to do this. And our societies I'm thrilled to see the consensus-based guidelines. I think we need more of those. These are desired. And our clinical gaps, I think for certain conditions, I think we have sufficient data to use TCD as we currently are. We use autoregulation testing in our ICUs and in our operating rooms. We use TCDs for neurovascular conditions for adults and children routinely. Stroke, brain death, and intraoperative anesthesia care, I would say for brain death, yes. For stroke, perhaps. For intraoperative anesthesia care, we use TCDs frequently for carotid endarterectomies, for example, to assess collateral flow during cross-clamping during the surgical procedure. So I think we can all, in our own respective fields, kind of draw this curve out for autoregulation and start to ask ourselves some specific scientific question. I enjoyed this article because these authors broke it down that way. And from here, the research questions and gaps can be easily addressed. So thank you for your time today, and I look forward to the discussion.